This is a case presentation of dead bag syndrome by Catherine Hu and Austin Nakatsuka at the Moran Eye Center, University of Utah. The authors have no financial disclosures. The case is a 60-year-old man who presented 8 years after uneventful cataract surgery with complaints of a line through his vision. In clinic, the lens was noted to be inferiorly subluxated but seemed to be loose in the capsular bag. In the OR, with the pupil widely dilated, you can see here that the lens is not well centered, but the haptics appear to be intact. The capsular bag is also devoid of scar tissue and appears completely clear. After filling the bag in anterior chamber with viscoelastic, the cannula is used to test the mobility of the lens. Manipulation with the Malyugin manipulator instrument shows that the lens is freely mobile within the capsular bag. The lens is then easily dialed out of the capsular bag and into the anterior chamber with no impediments, behaving similarly to a lens that had just been placed in the original surgery day. There was no obvious damage to the haptics or haptic-optic junction of the lens. The bag is again inspected, and there is no sign of any scar, remnant lens epithelial tissue, or fibrotic changes. In fact, even at 8 years post-surgery, the capsular bag looks more clear than we would typically see even a day or two after surgery. The lens is rotated and removed in 3 pieces using MST microscissors in an atraumatic fashion. Here you can see an excellent red reflex through the clear acellular bag. Of note, the surgeon who had done the initial surgery was very skilled and not known to polish the capsule excessively either. We believe this is a classic case of dead bag syndrome, a condition that has been recently published in the Journal of Cataract and Refractive Surgery by Werner Mammalis and authors. In this condition, the capsular bag is noted to be generally devoid of lens epithelial cells. Intraocular lenses are prone to dislocation either within the capsular bag, such as our case, where they appear to float within the bag. However, the capsular bag itself can also dislocate due to poor attachment of zonules to the capsule, similar to true exfoliation syndrome. In our case, the decision was made to place a 3-piece sulcus lens with optic capture. However, this was without prior knowledge of zonular instability and capsular dislocation. At the end of the case, the lens was tested and seemed to be stable and secure for the moment. There was no instability of the capsular bag, and the lens stayed very well centered. But in retrospect, it would likely have been better to fixate the lens, such as with the double needle flanged haptic scleral fixation method, to avoid late dislocation. The patient is currently doing well postoperatively with resolution of his symptoms, but he is being carefully monitored for lens dislocation.